This is Andrea Kane, and I'm here with you for HIT 445 Quality Management. We are still on week 3. We are now on chapter 12, Building a Safe Medication Management System. So if you want to turn your book to page 217, let's talk about medication management. These are the learning objectives based on the book itself. We'll probably touch on a number of things, but one of the things I want to make sure that you pay attention to is the FMEA tool, Failure Mode and Effects Analysis. That is very important. And yes, we'll talk about medication errors and adverse drug events, and we will talk about patient safety issues and touch a little bit on legal. So the FDA, what in the world do they have to do with medication management? Well, hopefully by now you have studied the FDA for a number of different reasons, and you understand that they are involved with medications, with approving drugs, with monitoring the safety of drugs, how those are dispensed, controlled, and all those sorts of things. And then the Drug Enforcement Administration is also involved in a number of activities, and you can read about that in your book. Department of Professional Licensing is also talked about here. And then we have To Err is Human. That report I believe you've read before about where it identified the number of patients who were dying on an annual basis because of errors, medical errors, whether that was medication related or something else medical. Leapfrog Group is one of those organizations that came into being around the year 2000 after the Institute of Medicine report came out. They wanted to talk about and rank and identify and improve safety. And so they have advocated a variety of quality improvement standards. They've really pushed hard for computerized physician order entry or provider order entry and evidence-based medicine. What is an adverse drug event? This is where a patient experiences some injuries resulting from a medical intervention that was related to a medication. It includes harm from an adverse reaction or a medication error. It's meant to be a term, adverse drug event, that something went wrong. Whether it was intentional or unintentional, something went wrong. And that's a good way to look at it. It's not meant to point blame. It is just simply to say this is serious and it happened. Medication reconciliation is the process of identifying the most accurate list of all medications a patient is currently taking, then comparing that list against the physician's admission, transfer, and discharge orders at each transition point along the patient's continuum of care. This is typically done by pharmacy techs in hospitals, and they are specially trained to do this. So safe medication management systems, one of the first steps is to make sure you select and procure your medications. This is done by having a formulary. If you haven't already had one as an organization, you definitely develop one and you annually review it. In your formulary, you identify when a medication is to be used, the medication's effectiveness, the risks associated with the medicine, and its cost. Formularies are also developed by insurance companies and others, and their focus is more on cost than anything. And also with hospitals, they've had to focus on cost. If you look at the amount of money that a hospital spends on medications a year, it is frightening. Absolutely frightening what they are charged for those. I don't want to get off tangent because I worked closely with pharmacy throughout my career and was there for them when they had some of their audits. But it is absolutely eye-opening. A formulary is a necessity, and it has to be approved by the medical staff, usually through the Pharmacy and Therapeutics Committee, the P&T committee. You need to make sure that drugs are properly and safely stored. That means that if they need to be at a certain temperature, you keep them within a certain temperature, and it's monitored 24/7, 365. You have to have double locked storage for controlled substances. If something has to be refrigerated, then it has to be refrigerated. If it needs to be kept frozen, it has to be kept frozen. If it's only good for a period of time before it expires, you have to be careful with that. Sometimes you are responsible for the patient's own medications. Examples, or an example that is very common, is that observation patients, if you go into the hospital and they say, well, we're going to put you in observation status, that is not an admission. That's not an inpatient admission. If you want, you can bring in your own medications, and they will hold those, store those, and dispense those to you, so that you don't have to pay for hospital versions of that. Because when you're an observation patient, they can charge you for all those medications. Whereas as an inpatient, it's rolled into your bill, into your DRG payment. And then when you're discharged as an OBS patient, then they give you back your medication. So they have to be able to do that. All medication storage areas have to be inspected on a regular basis. So you have all of those criteria or those steps that have to be done. Then you have to have a process for safe prescription and transcription of medications. How is it prescribed? How is that transcribed? Most places have computerized provider order entry for their medications, so the physician's actually going into the EHR to order the medications. That has helped reduce a lot of medication errors because you're not getting handwriting issues or confusion over dosages, because sometimes that's all programmed in. EHRs also have a lot of alerts in them to alert you when there's a food-drug interaction or a drug-to-drug interaction, or a contraindication, those types of things. But as an organization, you need policies and procedures to specify the required elements of how orders are written or communicated. And there is a do not use abbreviation list from the Joint Commission. If you get a chance, go out and Google or look up on the internet, do not use abbreviation list Joint Commission 2020, and it will pull it up, and you will be able to see which abbreviations are not allowed to be used outside of an EHR. Let's see. Acceptable use of verbal orders. When can a verbal order be given? And then if a verbal order is given, what are the read back, verify requirements? Because if you give a verbal order as a provider, first of all, the person that accepts the order has to be an RN, and they have to then read the order back to you and verify that that is the order that you are giving before they enter it and hit the button to move forward. So that read back, verify has to occur. Preparing and dispensing medications, a pharmacist has to review each prescription or medication order for appropriateness. So in small community hospitals or critical access hospitals where they don't have a 24-hour pharmacist, they have to have a contract with someone who can provide them with a 24 hours, 7 a day a week, 365 day a year pharmacist who can review every single prescription or medication order for appropriateness. The reason for this is it prevents prescribing errors, administrative errors, pharmacy errors, and discharge errors. And it gives you the examples of those. Medication selecting, compounding, packaging, labeling, all of that needs to be done by a pharmacist, again, to make sure that it is appropriate. I'm teaching pharmacology, which is HIT 120 right now, and so we're covering a lot of these things along the way and talking through them. A big reason why they want almost all of this to be done in the pharmacy by a pharmacist is because the nurses that are out on the floor are so busy, and it's very easy for them to become distracted. And if they're trying to figure out how to reconstitute or concentrate, use this concentrate with this diluent, errors have happened and can happen. Whereas in the pharmacy, it can be a lot more focused and quiet and enable the kinds of activities that need to take place. But packaging Packaging is important when it comes to look-alike medications. How do you make sure that two totally different medications don't look alike? You got to watch out for the packaging and maybe do some additional labeling if need be. Again, look alike, sound alike, um, spelled alike, pronounced alike drugs. You've got to do all of that. And you've got to make sure that when you store those so that they can be dispensed on the unit that you don't put them side by side. And make sure that the dosage is very carefully labeled. You don't want to put high and low dosages right next to each other where it's really easy to grab the high dosage rather than the low. Administering medications need to use at least 2 patient identifiers prior to the administration of medications, have a unit dose system, maintain an accurate medication administration record. It talks about 5 rights here, but there's anywhere between 5 rights and 13 rights, depending on who you talk to. What I'm teaching right now is 7 rights. But right patient, right drug, right dose, right route, right time, right reason, and right documentation. And then automated bedside point of care barcode scanning is now very popular. Most organizations have that with their EHR to help reduce medication errors. Monitoring the effects of medications on patients means that you don't just give the patient the medication and walk away. You come back within 15 minutes and check on the patient. You come back within 30 minutes and check on the patient. Is the patient seeing some kind of response? Is their pain level decreasing? Depending on what the medicine is supposed to be doing. Are they breathing easier? Different things like that. And then you want to gather the patient's own perceptions about side effects. Are they feeling jittery? Are they feeling sleepy? Those types of things. And then you want to evaluate your medication management system. Constantly be trying to identify and analyze medical errors, medication errors, near misses. You have a pharmacy and therapeutics committee that meets on a regular basis and goes over all that information. And the pharmacy and therapeutics committee information then is sent up to the medical staff executive committee. And from there, it's included in the med exec's report to the board of the hospital or organization. And then you also want to try and have a medication safety committee where that's a cross section of people. Some organizations like to do that. Some feel that their P&T committee does a lot of that work. It just depends on your organization. And it also depends on your pharmacy leadership. So you've got that. Drug diversion. Unfortunately, drug diversion is a real issue that has to be dealt with in most organizations. Drug diversion is when medication is removed from its usual stream of preparation, dispensing, and administration by someone who's involved in those steps in order for them to use the drug themselves or to sell it in a non-healthcare setting. So there has to be policies and procedures in place. There have to be audits and checks, especially when you're talking about controlled substances or easy to abuse or misuse items. If you see that you have patients that are supposedly given medications and they're still complaining about their pain, that's a clue. If you see that someone is documenting that they're wasting a lot of medication, you might want to actually have them have their wasting activities observed and witnessed by another employee to make sure it's actually happening and not being diverted. All sorts of stuff. The ED is one of the biggest areas that this can be a real challenge with, but it can also happen up on the units or even within the pharmacy. So, QI toolbox technique. Oh, I'm sorry, I just flipped in my book. On page 223, figure 12.2 is the Joint Commission's Do Not Use abbreviation list. This is from their 2017 release. There is a 2020 release. I don't see any appreciable difference there between the 2017 and the 2020, so no need to go out and take a look at that. And so we were on to FMEA. This is on the bottom of page 228, top of page 229. What is a failure mode effects analysis? This is a prospective or proactive tool that's useful in analyzing potential problems when introducing new systems or equipment or when looking anew at an existing process. This defines high-risk processes by using flowcharts, identifies potential failure points in current processes, and scores each potential failure by considering factors such as the frequency of failure, potential harm, and the likelihood that the failure will be detected before it reaches the patient. I worked in an organization that did root cause analysis and failure mode and effects analysis on a regular basis. In fact, anytime they had something that was a sentinel event, or even if it was not a sentinel event, but it was a serious situation, they would do an FMEA on it and come out of it with a lot of things that they could improve. And they included physicians in the FMEA, they included frontline staff that were involved, people from other departments. They really got a good cross group of people, including senior leaders in the room, and went through it and were able to make some really great changes moving forward. I was really proud of that organization. You get an example of an FMEA for the OR, and this is figure 12.7 at the top of page 229. Please just be aware of what an FMEA is and what it does, what it's meant to do. All right, that is it for chapter 12. I will be back shortly with a lecture on chapter 13. Thanks.